Well, welcome, Philip
Thank you.
Peters from Acorai. How are you?
Good. How are you?
Good, good. This is a little different stage than we did this in, what was it, about a year ago at my podcast?
Exactly. Yeah.
Yeah, I'm glad you were able to make it in for the interview. So obviously I'm very familiar with the technology you guys are building, but for the audience, tell us a little bit about what you guys are building at Acorai.
Yeah. Absolutely. So, in a nutshell, we're building a non-invasive cardiac and pulmonary pressure sensing device. Cardiac and pulmonary pressures probably needs no introduction to your audience, but they're effectively the blood pressure that we see inside the chambers of the heart. And what we know is that these are very important vital signs when it comes to managing heart failure patients more efficiently and more accurately. And to this date, they've only been available in invasive formats, so either through implantable sensors or through what's known as a right heart catheterization procedure or Swan-Ganz catheterization. And we're trying to take all that and make it non-invasive. And we believe this is important in the sense that this will redefine the way that we are able to manage these heart failure patients. So be a lot more accurate and specific about how we identify these patients, but also to see how they're responding to medical therapy and all the decisions surrounding these patients. So whether to discharge a patient safely, whether to take them down from a ICU ward to a general ward, all these types of decisions.
Down, yeah.
Correct. So all these types of decisions today are very difficult to make without these invasive products, and we're trying to make all that non-invasive.
So you talk about alternatives to what you guys are doing right now. It's right heart cath, which is obviously a really expensive procedure. I believe 80% of heart failure spend here in the U.S. is attributable to the inpatient spend.
Yeah.
Can you talk a little bit about how you guys might be able to impact that?
Absolutely, yeah. So to your point, most of the costs are inpatient costs. So we want to do two things. We want to keep them out of the hospital, and we want to reduce the cost of managing these patients when they're in the hospital. The way we think we can do that is, again, by improving the workflow, by giving physicians, nurses, and hospitalists a tool that would allow them to better understand and better navigate these patients. That will lead to better guideline retromedical therapy adjustments, that will lead to better diuretic adjustments, and then ultimately better discharge decision making, which will result in fewer readmissions. So
Right.
One of the big problems that we're sending home patients that have residual congestion. So over 40% of patients are actually not truly fit to be discharged by
Right.
some studies, and they look fine, they feel fine, and they get sent home, and then they come back with another acute decompensation for heart failure, and that hits the budget for the hospital in terms of they have to usually take this patient in at a loss.
Yeah.
And then you have the readmission penalty rates in the U.S., right, which further hamper that economic rationale. So all incentives are really aligned to keep these patients out of the hospital and then reduce the cost of managing them while they're in there.
So I think 27% of all hospital readmissions are attributable to heart failure. Is that accurate?
Yeah, sounds about right.
So that being said, have you guys looked at any of the other sites of care where because it sounds like the beachhead application will obviously be inpatient.
Yeah.
Have you looked at any other sites of care where this could be applicable? Could potentially in the ED or any of those other heart failure clinics, any of those markets, hospital at home?
Yeah. Well, so I think the reality is that wherever there is a heart failure patient, there is value to be had with cardiac and pulmonary pressure monitoring, right? So for us, it's about figuring out what is sort of the tightest, cleanest market for us to target, where there are natural coal points that we can leverage to really get into the hands of the gatekeepers of the industry, right? We kind of see it as partly a very clean workflow that we can target and make a huge impact in, but also as a way for us to build a brand in the industry of reaching out to the KOLs that will be using this, and then from there building into the outpatient setting. So there is a lot of interest from cardiology clinics. We have dialysis clinics that have reached out to sort of use this as a fluid management device.
Yeah, sure.
To your point, community care, kind of hospital to home / at home programs that are popping up all over the country. So the amount of use cases is really endless, right?
Yeah.
Because it's such an easy device to use that a nurse or a cardiologist or a hospitalist or even your mom could probably use it, right? So it's that simple.
Yeah, do you envision that the form factor would stay the same, or would there be an alternative form factor?
Yeah, so we are working on creating a separate product for the at-home setting. For now, we do have a handheld device, which is slightly larger than what you will have in the traditional wearable sector. The reason we are larger is because we very early on realized that we need performance, and when you want performance, you gotta get the best possible technologies into the device, and you gotta make some sacrifices on portability and battery life, right?
Right.
But when we kind of stress tested the market and talked to the KOLs, what they have today is so invasive and so expensive that anything that resembles that in a non-invasive format is like the holy grail of cardiology, right? So that's the benchmark that we had, and we set out to accomplish that. And we've just finished our pivotal Capture-HF study, enrollment for that study just yesterday, actually.
Congratulations.
But from there, we will build into trying to miniaturize the device into something smaller, that's more wearable, that a patient can bring home, that has no compliance or usability friction, which is a very important thing once you get into the patient's home.
Right. Yeah, good point. There's a ton of money flowing into this space. I mean, because it is the most mismanaged disease state, probably in all of medicine. How are you guys thinking about some of these wearable sensing garments, whether it's the vest or the edema sensing socks, patches? How are you guys thinking? Is that complementary to what you guys are doing?
Yeah, so we've kind of taken the opposite direction, and our engineers have a cheeky saying internally where we say that most of the space is under-engineered and over-patched, and we are kind of the opposite end. We have a slightly larger device, yes, but as long as it fits into the cardiologist's kind of lab coat pocket, they're happy.
Right.
And what we have that no one else has is performance, right? And I think back and back again, when we talk to cardiologists about the potential for non-invasive cardiac and pulmonary sensing, their eyes kind of like glare up, and they're like, I can think about 20 different use cases for this type of device, right?
Right. Quality is what matters the most, or precision, I guess, is probably what matters more so than form and function.
And I think we're a bit biased by the very successful history of heart arrhythmia wearable devices, where continuous use is very important because you want to detect silent arrhythmias. And when you have someone wearing something for 14 days, it needs to be small, it needs to have battery life, and it needs to be easily usable, right? And when you have those three design requirements for a device, any product, you're going to have to make some sacrifices on cost of the device and then also performance of the device. So that's really the two levers that you have to pull.
Right.
And we went the other way because that's what our market assessment told us to do.
Talk a little bit about the design of the device and just the sensors. I know it's called the SAVE sensor system.
Correct.
But talk a little bit about the sensors and what makes it unique.
Yeah, so this is the first of its kind multimodal sensor platform. So SAVE is an acronym to help us remember the types of technologies that we embody. So we're looking at, the S is seismic cardiography, so we're detecting very small chest wall vibrations on the surface of the skin with highly sensitive accelerometers and gyroscopes. So not entirely dissimilar to what the oil and gas industry has been. Yeah, it's correct, right? So, but the oil and gas industry in the US has been doing this for years in terms of assessing flow and pressure in pipelines non-invasively. We have so acoustics, so we're listening to the flow of blood and approximating pressure from that. And these are sort of our own highly specialized stethoscopes that focus on some very specific frequencies. We have the visual, which is photoplethysmography, so PPG, similar to what you will have in your Apple Watch.
Right.
And then we have ECG, which is the workhorse of cardiology, which allows us to kind of align these cardiac cycles so that we're looking at these sensor signals at the same time. And then from these sensors, we're able to extract variables that correlate with these cardiac and pulmonary pressures, primarily the wedge pressure, which is the most important one for heart failure management. And that's what this large study has been all about.
So it triangulates to give the physician a picture of where they're at, the patient's at.
And having this multimodal sensor platform allows us to detect different types of patterns that are combined but it also gives the device a whole different level of robustness to just having one type of technology, right? And I think that's something that the FDA has really appreciated, in that when this is eventually rolled out to the entire population, we want it to be robust in any patient population, any care setting,
Right.
whether there is loud music playing in the background or the patient's moving. We want to be
Right.
able to detect that and make sure that we get a really clean and good recording.
Yeah. So that there's no artifact or disruption to the signal.
Yeah.
So you're going to be hoping to be FDA approved, seemingly when, towards the end of the year, maybe.
So we're looking to submit towards the end of next year.
Okay.
And then we're hoping to have our de novo grant. So we're doing a de novo as opposed to a 510K, which adds a few calendar days to our kind of processing time. So we're hoping 2026 is sort of when we aim to be on the market. We work very closely with the FDA as part of the FDA TAP pilot, which has been a great program so far for us. So it's very helpful and collaborative, just mentality that we've really appreciated.
It's great. Have you guys thought at all about reimbursement or?
We have, yeah. So, for the inpatient setting, the economic incentives are already aligned.
Yeah.
So,
kind of a no-brainer.
High losses on average for these admissions because these hospitals aren't getting paid enough by CMS to admit these patients, right? So the DRG codes that exist today just aren't paying enough, right? So that means that there's all incentives aligned to reduce the cost of managing those patients and then reduce readmissions so that your whole CMS budget doesn't get penalized by the penalty rates that you have for readmissions. On the outpatient side, we are starting to look at Category 3 codes. So we're going to have to create our own code going forward, and we'll be looking to submit that application sometime next year. But based on our interactions with AHA and ACC and the other societies, there is a lot of interest for supporting those types of applications because of the huge unmet need of just getting better tools out there that can help us understand these patients better.
Yeah, and then the inpatient, that what you guys are doing falls right in line with the transition from bundled payments to quality-based payments and value-based care.
Yep.
I would think that this would be pretty much a welcome technology in that environment.
Yeah, I mean, we're not marginally improving a technology here. We are really kind of redefining the way that heart failure patients can be managed.
Yeah.
And the primary outcomes is quality of life and quality of care, and then reducing the cost of that care. And I think we tick all the boxes for where care is going in the U.S. and globally.
Yeah. Well, thank you for joining us.
Thank you.
We'll look forward to seeing what happens in the coming year, and maybe we can have you back for a visit next year at TCT.
Yeah, absolutely.
Thank you, Philip.
Thank you.